Okay, I think we'll go ahead and get started. We're like a couple minutes past noon. Thanks everyone for joining us at our lab advisory meeting back on our regularly scheduled second Monday. Um, we're going any Monday holidays. We're back on track. So we'll just jump right into it. We asked Derek Julian from the DHHS to kind of give a little talk about what's going on with H5N1 in Nebraska. Derek, are you with us? I thought I saw you were on.
Yep, I'm here.
Do you need to be able to share your screen
Yeah,
or
if I could, I threw a couple slides together, like you said, to give a little H5N1 update, not only Nebraska, but a little national
yeah,
overview quick as well. And also, I threw some seasonal flu and RSV slides in there as well. I figured I can do maybe my little
yeah,
program update while I have the mic, so to speak.
sure.
Cool, thanks.
You should be able to share your screen now.
It's saying it's disabled right now. Let me keep trying. Oh, I think we're good now.
Okay.
Just got to find. Okay, I think this will work. I might have to pull up the PowerPoint then. Okay. Do you see a PowerPoint now?
I do.
Okay, cool. All right. Let's see if we can get this to work correctly. Is that showing full screen or do you see like the
It's showing
notes?
like the PowerPoint, yeah, the notes
Oh, it is.
side.
What we gotta do? Swap. Does that look better? Or
That
is this
is
still
the
like
same right now.
what in the world? Okay. Let's see. Sorry about this, folks. Okay. I'll just keep it at this, then we'll just do that and we'll do this, and it should be good.
Yeah.
But all right, cool. So, good afternoon slash morning, everyone. So, just really quick, wanted to give an update on highly pathogenic avian influenza H5N1. Firstly, a quick little national picture. So, some of these numbers on dairy cattle and poultry flocks I'm going to share. This comes from USDA's website. They have like a couple little dashboards put together. So I pulled this data late last week. So for dairy cattle detections in total, since the start of the outbreak, there has been just under 1,000 confirmed herds across 16 different states. And looking at more recently, within the past 30 days, there has been just 35 confirmed detections in two states. And those two states are California and Nevada, with I think almost all of those 35 confirmed detections begin in California, except one or two in Nevada. Which has been true for most of these herd detections. A lot of them have been coming from California. Now, looking at poultry, and within just the past 30 days, there's been 137 confirmed flocks. That's both commercial flocks and backyard flocks. So I included a snip of USDA's dashboard specific to poultry here to the right. At the very top, we can kind of see a breakdown between commercial and backyard flocks by month over the past 4 months. And then the bottom is just a countrywide map showing the number of detections. So the darker green state is the more detections that they've had. So I'll go into Nebraska here in a little bit, but keeping it on the national level. In humans with H5, the current case count reported out by CDC since the start of 2024 is at 67 confirmed cases. Now, of these 67, 40 were associated with exposure to dairy herds, 23 with poultry farms. One was noted as having an other animal exposure, and then three, there was not an exposure that was able to be identified after epidemiological investigations. And then of these 67 cases, there has been one death, as some of you may have heard in the news. I think it was maybe a few months ago now. A case out of Louisiana was hospitalized and then ultimately did pass. And that, to my knowledge, that one case, or this one case that passed, is also the only case that has been hospitalized due to H5. So CDC still holds that the general public health risk for H5 is still low, although obviously there's going to be an increased risk for persons in higher risk settings, such as being on an infected dairy herd or poultry farm and being around those sick animals. All right, moving down a little bit to Nebraska specifically. So to date, there still has not been a confirmed HPI H5N1 detection in dairy cattle. We continue to maintain a good standing working relationship with the Nebraska Department of Agriculture, as they are continue to be the lead agency in this H5N1 response in animals, both dairy cattle and poultry. So with poultry, we have seen detections all the way back since 2022, when really this H5N1 kind of came onto the scene more recently. And in Nebraska, we have confirmed 28 total infected flocks, as 28 is made up of 18 backyard flocks and 10 commercial flocks. I wanted to scope this down a little bit to more recently, since the start of 2024. So since 2024, we've had 8 detections, 5 backyard flocks and 3 commercial flocks, with the most more recent detection coming into backyard flocks that NDA reported in late January. And when we get these positive flock detections, NDA notifies us, so then we can work with our local health departments to try to identify persons exposed to these flocks, and we can do 10-day symptom monitoring. And we're had pretty good success, I'd say really good success in monitoring these folks, as our local health departments so far have been able to monitor 100% of these persons exposed to flocks. And I know other states, it can be a struggle to be able to do this to get 100% monitored rate. So we're really pleased with that. And we are also pleased to report that we have not had any human H5 detections in Nebraska to date. So just a couple reminders. These reminders shouldn't be new news, so to speak. We've shared these previously, but I just want to continue to reinforce, as H5N1 is still out there in animals. So if your lab performs molecular influenza testing and receives an influenza A no subtype result, continue to please notify us here at DHHS or MPHL, and then send that specimen to MPHL for further subtyping. So again, that message has been shared quite a bit from us. And I also linked out a HON that would have went out in mid-January. Hopefully you've all seen that. But this was a CDC HON. And we added a little bit of Nebraska specific information as well, but just talking about a request to increase influenza subtyping on influenza A hospitalized patients. So for more information on that, check out that link. Secondly, if your laboratory were to ever receive a call from a clinician, someone from public health, whoever, on testing a patient with suspected HPI infection, please direct them to the state for approval. And then we have a pretty low threshold for approval. So once approval is received, we can work together to get appropriate specimens to MPHL. And then just wanted to continue to note that if a patient were ever to report conjunctivitis, conjunctival, I think that sounds better. Conjunctival specimen should be collected and sent. That recommendation is still true. And then finally, I pulled a few resources from CDC's web pages that I thought might be good for you all here. Just one giving a general overview of high-path avian flu, and then also a couple specific to specimen collection and testing, and also lab biosafety. All right, so that is it for my little high-path update. Like I said, while have my screen shared, I just want to give a little update on seasonal influenza. So as everyone here is probably well aware of, we are seen a lot of influenza activity driven primarily by influenza A. So this figure here hopefully looks familiar. So it's our influenza A and B lab positives reported by week since the start of October, overlaid with our overall influenza test positivity. So just week ending here on 2/1, our positivity jumped up to 35%, which to date has been our peak. And although it's not on this graph, just before this call, and I didn't have time to update this figure, but looking at what our preliminary data for week ending the 8th of February, our total influenza lab positives were pretty similar to this week ending on the 1st, although the test positivity did increase by 1.5% roughly. So I'm hopeful that this could be our peak and we can start seeing a downward trend here sooner rather than later. Here's just looking at our influenza A and B test positivity compared to the past few years. So we've seen similar levels of influenza A that we observed 2 years ago in the 22-23 season. That's this gold color here. So we're not seeing unprecedented high levels of influenza. This tends to be a routine level that we see when we see peak influenza. So I just wanted to call that out. And I created this figure. So what we're looking at here is the number, or I should say the proportion of influenza subtypes. So influenza A, H1 and AH3s by week. And this is not only data from NPHL, but also includes flu specimens that would have been subtyped at hospital labs who had those subtyping capabilities, such as like a BioFire, for example. And looking at the right half of this graph here, a little more recent, for most of the season, we've seen more H3s, this lighter blue, but the past couple weeks, starting to see a little more of influenza A H1s here in the dark blue. And on the note of just subtyping, I wanted to take a quick second just to thank everyone on this call for submitting specimens to NPHL for subtyping, as well as being able to do subtyping locally at per the request of the HON. We have seen, I think, the most specimens at NPHL for influenza specimens, should say, at NPHL to be subtyped, which is great. And just really wanted to show my appreciation for that, and thank you all. And finally, to see what we're doing or seeing with RSV. RSV2 has been increasing, just like flu, albeit not quite at the same level, so to speak. Our positivity did plateau a little bit this week ending 2/1, but looking at preliminary data for week ending the 8th of February, it looks like our data is going to go up again, once again, with RSV. So still seeing high levels of RSV and no sign, at least yet, of a downward trend there. All right, with that is all I have. So I will go ahead and stop sharing and check the chat if there's any questions, but also happy to take questions right now.
Say Derek, this is Pete. I was noticing on some of your graphs, you're starting to see an increase in some Bs showing up, influenza B. I'm just curious to know, you keep track of what percent of those come from antigen tested versus PCR tested?
Yep, we do. And
from antigen?
Yep. So we do track that and actually include that data in our public facing reports. And by and large, most of them have been antigens positives for our flu Bs. Haven't seen a whole lot of B PCR positives just yet. Okay.
So you kind of wonder how many of those antigen Bs are really true positives.
Yep. Exactly. Yep. Question that a little bit too. Yep.
Yeah. Okay. Just curious.
Thanks.
Thanks, Derek. Are there any other questions for Derek there? I am actually going to jump to the third item on our laboratory topic agenda there, kind of piggybacking off of what Derek said. This is not so much an update as there's just again, say thank you to everyone who's been submitting like like Derek said, we've been getting a lot of submissions, and that helps us out tremendously. It's not just flus, it's everything. It's the antimicrobial resistant isolates. Uh, you know, pretty much all the work that we do here is dependent on the relationship with the clinical labs to send things in for testing. So thank you. Shout out to everybody. And then so jumping back up to second item on our agenda there. Late last week, the CDC sent out a health advisory about a recently confirmed outbreak of Ebola in Uganda, caused by the Sudan virus. They issued a travel health notice level 2 for enhanced precautions. So I just kind of wanted to use this as an opportunity to mention some recommendations from the CDC, which we've heard before, but it never hurts to just kind of reiterate. They're stressing following standard precautions to prevent laboratory-acquired illnesses. In cases where there would be a person under investigation at a hospital, travel-related, laboratory testing is required during the monitoring of that patient's diagnostic testing. So if it's at your hospital, you're still required to do all the regular laboratory testing. So, you know, maybe look over procedures relating to donning and doffing PPE and packaging and shipping, which brings me to another point here. Becky and I, along with the Region 7 Emerging Special Pathogens Training Center, we're working on a collaborative work group. I might have mentioned this before, but sometime late in January, Jackson Gruber, the head of the RSPTC, sent out a survey kind of gauging interest in cooperating with this working group, looking for clinical labs and other laboratories to kind of support public health to join this working group, or at least, you know, be a part of the discussion for testing menus, training and education, best practices, concept of operations, and kind of anything else that any other topics that come up during just, you know, semi-regular meetings. So if you did not get the link to that survey, or if you're interested or you want to learn more about this working group that we're trying to put together, email us and we'll send you some additional information. Are there any questions about that? The CDC Han, the working group, advanced precautions. We're going to be, dusting off some of the trainings that we used to offer. And we're going to be working with NETEC and the Region 7 Special Pathogens Training Center to get this done.
Ben, this is Pete. Thanks for sharing that information. I will say that the Lassa fever case that occurred in Iowa kind of precipitated this. What actually happened there was there were 3 different laboratories that had people exposed to specimens from this patient and considered high-risk exposures. So we're trying to make sure that people recognize the fact that these samples could end up in any laboratory, and we need to be prepared for these high-consequence pathogens showing up. So that's why this discussion and why this training is so important. So thanks for sharing that, Ben.
Yeah, you're no problem, Pete. Thank you. And like I said, if you have questions, feel free to reach out to us, or if you have suggestions on, you know, what kind of training could help your laboratory right now, we look forward to those as well. So if there's no further questions about the laboratory topics, we can move into our round robin, our epidemiology round robin. We'll start with hospital-acquired infection and antimicrobial resistance. If Ishrat is on the call. Looks like she's in there. Is someone available?
I'm in the call.
Oh, sorry.
So we do have some Candida auris cases that are we identified. So we are working on those. I think we were able to connect that to a patient who sought care in another state outside. So this is what we're working on right now. So that's the update we have on our end. I don't know, Dr. Ashraf, you wanted to add something else, more details, or
Yeah, I
should be
think
fine?
I think yes. One thing I will say is, as you mentioned, Ishrat, the case was exposed in an outside state and developed infection here, or at least was diagnosed with infection here in Nebraska. So that is usually not a concern for us because now usually that is means that we are not seeing transmission. But we also in this situation, when we start looking, we have identified transmission within the state. So we have additional cases that actually originated from this cases. So we are still doing that investigation to identify, the extent of the transmission. We are hoping that this is just a localized, contained transmission event and not necessarily widespread. Um, but that investigation is still ongoing. Why is it important for the rest of the colleagues here is because um, this is a situation where now time and again we are now seeing a case comes from outside and then we start to see transmission within our state. We need to be able to identify if any CRS case is if we are suspecting a CRS cases. So if your facility do not have, if your lab do not have the ability to go into the level of a species of what Candida species is there, or if you are suspecting that there will be a misidentification of CRS with something else and you are suspecting that, reach out to the public health lab and they will be able to help on those identifications, especially if a Candida is growth from sterile sites. I think, and if your facility is not able to do the species identification, then NPHL is going to be able to help out with that situation. I think it may not be a bad idea to look at the Han that we sent out last year. It has a whole lot of guidance on what needs to be done to kind of keep the level of awareness, our threshold kind of low to when to go and look for CRS. Those guidance that we published out last year in the Han is still going to be useful at this point while we are working on this particular transmission event. Um, Dr. Ivan, is there anything that you want to add for the NPHL aspect of how we can make sure that we are capturing these cases?
No, I think you hit it pretty good. I did put in the chat that Canada Oris now has a new name, a new genus name. I'm not even sure how to pronounce it, Candidosma aureus. So just in case you see that genus come across as a name, that is the valid name for this species. So we will continue to use Canada as well. Why not? We love name changes, right, Solomon? So
Yes, we do.
anyway, I think the good thing is we have not seen a lot of this in Nebraska. And I do think we've been pretty good about looking for it. We've had people sending us isolates for confirmation testing, and I don't think we've seen one in our lab yet. I remember maybe well, way back when we had those 3 or 4, didn't we? That one exposure, but pretty far in between.
Yeah, and almost exclusively, we are seeing this transmission happen in the state after it has been introduced, because the cases that we have already have in the state, we know about them, and we have
Right.
the right precautions kind of started on those patients. but these are the cases that comes from outside and then start transmission event in Nebraska. So I'm actually, even recommending facilities right now to start looking into maybe setting up some kind of a admission colonization screening program where, anytime you have a high risk patient, out of state traveler, or maybe that's the patient you actually want to
Sure.
screen for Candida auris right at the time of the admission. So that's something that people should at least think about.
Sure, maybe more of a travel history coming from those states that have a lot of cases. And there are, if you look on the maps, there are some states and cities that are pretty high incident.
Agreed.
Okay, thanks, Pete, Dr. Solomon, Dr. Ashraf, and Ishrad. Are there any questions concerning the Candida auris? Okay, and so, yep, NPHL is collecting specimens for confirmation for C. auris if need be. So we'll move on. Is Sai available to do the COVID-19 update?
Yes, just want to report that we don't have any significant updates in terms of metrics. Everything is nothing is out of normal as of now.
Okay, good. Derek gave us his update, so we'll move on to enteric outbreaks with Claire.
Hi, no major updates. Noro still kind of high, but otherwise nothing from us.
Okay, thank you, Claire. Jeff, are you available for arbovirus?
Yep, I'm here. No major updates really to report. There was a couple new places, I guess, added for travel alerts for Oropouche virus, Espírito State in Brazil, and then I forget what the state was in Panama. So that's about the only real big update in terms of arbovirus stuff at this point. Just some additional stuff for travel alerts.
Thank you, Jeff. We'll move on to TB.
Hello, everyone. I don't really have any big updates. The only thing I did want to mention is there was national press regarding the TB outbreak in the state of Kansas, affecting the Kansas City area. We are in the process of issuing a HAN. So we're just getting that through our approval systems here. The big thing I just want to pass on to our labs, as with always, labs should continue to submit your isolates to the public health lab for genotyping and drug susceptibility testing if not done through the originating lab. And if you do have questions, please let me know by calling the program, or NPHL is a great resource as well. That would be the only update I would have at this time.
Thanks, Kristen. We'll go on to Tammy for the STD program. Tammy's on. It doesn't look like it. Okay, and we will finish out here with the lead testing.
Good morning and good afternoon. Lead does not have an update at the moment. Thanks.
Okay, great. Thank you. Are there any questions that came up during that speed round of epidemiology updates? Okay, some final notes here. Becky and I are getting close to sending out the motility study that we asked for volunteers for a couple of months ago. Look forward to that in the next couple of weeks. And then our packaging and shipping class at the beginning of March 4th and March 6th. We have some seats available for that yet. If you have laboratorians who haven't gone through packaging and shipping and need certification, we'll open it up for a second. Is there any new staff or any other comments that need to be made? Okay, so next meeting will be March 10th at noon Central. Thank you, laboratories. You're free to go. As always, thanks for joining. We'll see you next month.